Okay, so we will talk about the lower limb. This is the part one of the lower limb, the two lectures. Now, to start with, few things about the entry points to the lower limb, gateways to the gluteal region and lower limb, since we are doing gluteal region together with the lower limb. Now, one important entry point is between the pelvic bone, hip bone, and the inguinal ligament. Below the inguinal ligament, your femoral vein, artery, femoral nerve, and lymphatic channels, they pass through that space. That is an important space, therefore. Then below that, you have another small entry point through the obturator canal. That is also into the medial aspect of the lower limb. Then at the back, there are several gateways again. One important gateway is through the great sciatic foramen. It is divided into two parts, small upper part and large lower part. Through the upper part, which is above the piriformis, in the great sciatic foramen, there is one entry. Then below the piriformis, where you get sciatic nerve and all. So then you have another entry through the lesser sciatic foramen. Mostly structures go into the perineal area. So this is, this is a nice way of putting it to start with. Then we will start with the superficial veins and nerves. Now, when it comes to superficial veins, the basic things about superficial veins, the superficial venous system starts from the dorsal venous arch. Of course, there are veins from the sole draining through the metatarsal bones into the dorsal venous arch, especially when you walk. The venous blood will get pumped into the dorsal venous arch. And from the medial aspect of the dorsal venous arch, great saphenous vein will start, which passes immediately in front of the medial malleolus, ascends on the medial aspect of the leg, passes about hand's breadth or 5 centimeters behind the medial border of the patella here at the knee. Then it ascends on the thigh, curves towards the anterior side, and passes through the saphenous opening in the fascia lata and enters the femoral vein at the saphenofemoral junction, which is a very general superficial description of the great saphenous vein, course of the great saphenous vein. And there are many tributaries entering into the great saphenous vein. Some are named important tributaries. We will just take a look at some of these tributaries later on. And then the other important point is associated with the great saphenous vein, there is a nerve. Actually, the nerve is in front or anterior to the great saphenous vein. That is called saphenous nerve, which is a branch of the femoral nerve. Actually, it's the only branch of the femoral nerve entering the leg. Below the knee, that nerve is going down. All other branches, they are used up above the knee. Then, when it comes to the small saphenous vein or short saphenous vein, it starts from the lateral side of the dorsal venous arch, passes posterior to the lateral malleolus, then ascends on the posterior aspect of the leg, pierces deep fascia, which is at the roof of the popliteal fossa, and enters the popliteal vein at the popliteal fossa. Then there is another important thing, the nerve that accompanies the small saphenous vein is the sural nerve, which is a fully cutaneous nerve supplying the lateral aspect of the foot. Then there's a general rule. There are more valves in the lower limb than in the upper limb. So that says that the upper limb also has got valves inside the veins, but less in number compared to the lower limb. It's understood because blood has to go against the gravity in the lower limb. Then more valves in deep veins than in superficial veins. Okay, so in lower limb, when you compare the number of valves, there are more valves in the deep veins. So that's general rule. We'll talk about veins a little bit more towards the next slides. Then, okay, we mentioned about the nerves accompanying the two veins, saphenous nerve and the sural nerve. Okay. Then we will take a look at some of the important nerves and anything, any clinical situations associated with cutaneous nerves. Now, number one is lateral cutaneous nerve of the thigh. Um, this is coming from the lumbar plexus. Now, the lateral cutaneous nerve of the thigh is also called uh, lateral femoral cutaneous nerve. Then the thigh is dropped there because it says femoral. Either you call it lateral cutaneous nerve of the thigh or you call it lateral femoral cutaneous nerve. And this nerve can get compressed under the inguinal ligament because it enters the thigh immediately under the inguinal ligament at the lateral end of it. Okay, very close to the anterior superior iliac spine. It enters the thigh. It can get compressed there, and when it gets compressed there, you can get a condition called meralgia paresthetica or Bernard-Roth syndrome. So you will get this numbness or tingling sensation on the lateral aspect of the thigh. So on, I'm not going into details of that. Okay. Then the saphenous nerve, I already mentioned its relationship to the great saphenous vein, and this is the only branch of the femoral nerve entering the leg and the foot. Then superficial peroneal nerve, we will talk about in detail about the superficial peroneal nerve later. So this is actually the nerve of the lateral compartment of the leg. It gives off its motor component to the two muscles in the lateral compartment of the leg, the two peroneal muscles in the lateral compartment of the leg. Then the cutaneous part, the remaining part, it emerges to the anterior aspect of the leg, and it actually supplies the dorsum of the foot. So then the other important one is the deep peroneal nerve. Deep peroneal nerve is the nerve of the anterior compartment of the leg and the dorsum of the foot. Both muscles are supplied by the deep peroneal nerve. It is largely a motor nerve, but the small cutaneous component that is there in the deep peroneal nerve supplies the skin of the first digital cleft or the skin of the first web of the foot. Which is important, when you look for deep peroneal nerve damage, you can actually look for sensory in that area because the surrounding that, the sensory supply is different from superficial peroneal and maybe, a little bit of saphenous up to the ball of the big toe. So this, therefore, you can actually, if you see numbness in this area, first digital cleft, then that is suggestive of deep peroneal nerve. Of course, you can look for motor loss, wrist, foot drop and all that. Okay. Then posterior cutaneous nerve of the thigh, okay, it supplies the posterior aspect of the thigh. More than that, it is the cutaneous nerve that emerges from the greater sciatic foramen below the piriformis together with the sciatic nerve. That's why, I mentioned it here especially. Then the sural nerve, again, I mentioned, this is the nerve that is closely associated with the small saphenous vein. And the other important thing is, rarely, when you have to do nerve biopsies, sometimes, to diagnose certain peripheral nerve diseases, or for research purposes, sometimes, this is a nerve that can be biopsied. Okay. So usually you don't biopsy nerves, but if you really need to biopsy, sural nerve is one nerve that can be biopsied. Okay. Definitely you will have a sensory loss, but it's less problematic. Okay. Then another slightly important thing, the heel of the foot is supplied by medial calcaneal nerve, which is a branch of the tibial nerve. Not very important, I think. Then the genitofemoral nerve. Now, when you learn the inguinal canal, you learn that there are three nerves associated with the inguinal canal. Two passes through the inguinal canal, one pass above the inguinal canal. The the nerve that passes above the inguinal canal is iliohypogastric nerve. So it is not inside the inguinal canal, it's above the inguinal canal. Then two nerves pass through the inguinal canal, genitofemoral nerve and the ilioinguinal nerve, genitofemoral nerve and ilioinguinal nerve. Genitofemoral nerve, which I have shown here, it has two components, femoral component and the genital component. Femoral component is given off here to the anterior aspect of the thigh. When you do procedures on the femoral vein, if you want to catheterize the femoral vein, you give local anesthesia. I have a slide on this. Actually, this is the nerve that you block using local anesthesia. Okay, other nerves can get blocked, but this is the main nerve that is blocked, this branch of the genitofemoral nerve. Then the genital branch of the genitofemoral nerve, it actually passes along the inguinal canal further. It actually supplies the cremasteric muscles and all. Okay. Then the other one is the other nerve passing through the inguinal canal, ilioinguinal nerve. So that one, it supplies the perineum, labium majus or in females, or scrotal skin in males. It also supplies the upper medial aspect of the thigh in the groin area. So skin over the pubic symphysis is also supplied by, in that the whole area is supplied by the branches of the ilioinguinal nerve. Okay, if you again take a look at the structures related to malleoli, I have already mentioned the great saphenous vein and saphenous nerve several times, which is related in front of the medial malleolus. Then behind the medial malleolus, the dotted line I have shown here, behind the medial malleolus, you have an important tributary of the great saphenous vein, which is called posterior arch vein. We will talk about it later. Then on the lateral aspect, as we said before, posterior to the lateral malleolus, you get small saphenous vein, which is shown in dotted line here, and the sural nerve. Now, this is the superficial ones, and deep structures. Again, if you go to the medial malleolus, the structure that is very closely related to the medial malleolus is the posterior, the tendon of the posterior tibialis posterior muscle, which actually grooves the medial malleolus. So if you take the bone, you can see this groove on the medial aspect of the on the posterior aspect of the medial malleolus. You should see this if you haven't noticed this before. Then behind that, you get other flexor tendons, flexor digitorum longus, and flexor hallucis tendons. Then further behind, you have the posterior tibial artery and tibial nerve. On the lateral aspect, behind the lateral malleolus, deep structures, you have the two tendons, peroneus brevis and peroneus longus tendons. Okay. Then continuing with the superficial and deep veins, now I mentioned there are certain tributaries of the great saphenous vein. Now there are four small tributaries which correspond to the first four branches of the femoral artery actually. When we talk about the femoral artery, we will come back to that point. Now parallel with those, small branches of the femoral artery, you have four tributaries of the great saphenous vein entering the great saphenous vein. So they are the superficial circumflex iliac from the lateral side, and on the medial side you have superficial epigastric vein, then superficial and deep external pudendal veins. So you have small arteries with the same names actually. We will come back to it. Now, why these vessels are important is that when you do high tie, okay, now the procedure is less frequently used nowadays because you have other ablation, procedures to treat varicose veins. But if you do saphenous vein cut down at the saphenofemoral junction as a treatment for varicose veins in the distribution of the great saphenous vein, you must identify some of these veins, not some actually, all of these veins, or if there are additional veins, and tie them. Otherwise, okay, you might cut the saphenofemoral junction and block it, but blood can drain into the great saphenous vein through other veins into the through these small tributaries so that you will get recurrence of the varicose veins. So you have to block these small veins. For that purpose, it's important. Okay, otherwise they are just small uh, tributaries. Then there's a large tributary, somewhat constantly present one, which is called anterior accessory great saphenous vein, or it's called anterior accessory vein, which drains into the great saphenous vein just before it enters the femoral vein. Then, there are many other tributaries which we are not talking about, but another important tributary is the posterior arch vein, which I showed you in the previous slide, which passes behind the medial malleolus, ascends, and it drains into the great saphenous vein very close to the knee joint. Okay. So the posterior arch vein is given another name. It's called posterior accessory saphenous vein also, PASV. Now that name is the new name actually. Posterior arch vein is the old name. I like to use that name. It's simple and short name, posterior arch vein. Then about the deep veins. Now, first thing to remember about deep veins is that the deep veins, they follow the arteries, and they follow the arteries in the form of venae committantes. Now, the arteries. You have the femoral artery, which is the continuation of the external iliac artery. Beyond or distal to the inguinal ligament, external iliac artery is called femoral artery. Then the femoral artery passes through the femoral triangle, adductor canal, and at the adductor hiatus of the adductor canal, where the adductor canal ends, it opens into the popliteal fossa, and then it is called popliteal artery. Not It's not open into it. It passes. Okay, it enters the popliteal fossa, and there it is called popliteal artery. Then at the lower border of the popliteal artery divides into its anterior tibial and posterior tibial branches. So posterior tibial artery gives another important branch, which is called the peroneal artery. So you have femoral, popliteal, anterior tibial, posterior tibial, and peroneal. Okay, these are the main arterial structure. There are branches, of course, important branches. We'll talk about it later. Now, of course, you can add the profunda femoris artery, and there's a vein corresponding to that also, which I have missed in this image. Um, so the corresponding veins are these. Okay. So they bear the same names as arteries. Okay. So it's straightforward. But the only thing is, even though I have drawn them as single vessels, they are usually in pairs. Okay, except for the femoral and popliteal, others are in pairs. Okay. Then if I add superficial and deep together, so the black ones are deep veins, blue ones are superficial veins. We have already discussed in this lecture about the dorsal venous arch, great saphenous vein and small saphenous vein, and how they enter the deep veins. Great saphenous vein enters the femoral vein at the saphenofemoral junction. Small saphenous vein enters the popliteal vein at the popliteal fossa. Then I have also added here the posterior arch vein, or the PASV, which enters the great saphenous vein, which is an important tributary. Now, you know that in the lower limb, superficial veins drain into deep veins through perforating veins or perforators. Now, the superficial veins, they lie in the superficial fascia. Deep veins, they lie deep to deep fascia. Some of them are inside the muscles like gastrocnemius or soleus. So the perforating veins, they connect the superficial veins to deep veins. In doing that, they actually pierce or pass through the deep fascia to connect the two. So that's an important thing to remember. Then the other thing, I'll show you that also. Then the other important thing is, okay, the superficial veins and deep veins, they both have got valves directed towards the heart. And blood can drain through the superficial veins and deep veins towards the heart. Uh, and the perforating veins, their valves are directed from superficial to deep. Their valves are directed from superficial to deep. When the muscle pump acts during walking and all, when the deep veins are squeezed, pressure increases inside the deep veins and blood is pushed towards the heart. And uh, when the muscles relax, the pressure drops in the lower part of the veins, but the blood is prevented from coming down because of the valves. So due to the low pressure in the deep veins now, blood will drain from superficial veins through the perforators into the deep veins because the valves in the perforators open towards the deep veins. And when the muscles contract, the perforator valves will close and prevent blood going back into the superficial venous system. So that's how it works. But when you have incompetent perforator valves, what happens is when the pressure increase in the muscle pump system, blood will, rather than going towards the heart, blood will return into the superficial venous system, engorging, elongating the superficial venous system, giving rise to varicose veins. So that's why in deep vein thrombosis and all, you get varicose veins more often. Then the other important thing is when it comes to perforators, there are so many variations in the position of perforating veins. And even though I have shown few of them here to represent, there are hundreds of perforators in the leg and thigh altogether, if you check in literature. So there's no point in we discussing about the positions of perforators at this level. Maybe you can do ultrasound and all that and find out in your clinical practice. So, but the important point is, I have mentioned some important points here. There are more perforators in the leg than in the thigh. So that's a general rule. More perforators in the leg than in the thigh. And the most perforators in the lower limb are on the medial side rather than on the lateral side. There are few perforators only on the lateral side. And most of these perforators in the leg especially, they connect the either the posterior arch vein or great saphenous vein to the posterior tibial vein. So most of them are between the posterior tibial vein and the posterior arch vein or great saphenous vein. And when it comes to the thigh, the perforators are between mainly between the ones that are on the medial side, mainly between the great saphenous vein and the superficial femoral vein. We'll talk about superficial and deep femoral veins later. Superficial femoral vein is the femoral vein inside the adductor canal. And when these connections are made, they are made when the femoral vein is inside the adductor canal. Therefore, you can call them adductor canal perforators. So you give them different names, you call them mid-thigh perforator, above knee perforator, below knee perforator. Then you have other specific names like you can see the names here. I'm not going to read through this. So you need not get confused, about these terms too much because it's a lot of variations in this one. And when it comes to the leg also, leg and the foot, there are some leg perforators and there are some perforators in relation to the ankle, okay, on the medial side. And on the lateral side, lateral perforators, they connect, when they are present, they connect the small saphenous vein with either the peroneal vein or the anterior tibial vein. I think the more common one is the peroneal vein, I think. Okay. So this is all about the veins I want to talk about, I think, other than this, clinical applications of them. Now, you can do femoral vein catheterization below the inguinal ligament. I mentioned already when you do femoral vein catheterization, you give local anesthesia here, you are actually blocking the femoral branch of the genitofemoral nerve. We mentioned it. And when you do this, few things to remember, you see few, anatomical relationships that are important. Since the vein lies immediately medial to the artery, the best way to catch the vein is to palpate for the arterial pulse. So you palpate for the arterial pulse below the inguinal ligament and you go immediately medial to that. So you don't just go just below the inguinal ligament, you take about 2 finger breadths below that. Okay. So you look for the pulse, you go 2 finger breadths below the inguinal ligament, just medial to the femoral pulse, then you can enter the femoral vein. Okay. Then you can do a saphenous vein cut down. Previous one was femoral vein. Catheterization, this is saphenous vein cut down can be done like in hypovolemic shock in burn patients or any other condition where you cannot access veins in the upper limb. You can go for saphenous vein. Either you can put a cannula. If you still can't find it, you will do the cut down to find the vein. When you do the cut down, you do the cut down immediately in front of the medial malleolus, and you have to give local anesthesia. When you give local anesthesia, you are actually blocking the saphenous nerve, okay, which lies immediately in front of the vein. And when you actually cut the skin and go into the subcutaneous tissue, you will see the saphenous nerve lying in front of the great saphenous vein. Make it a point to preserve the saphenous nerve. Otherwise, at the end of the procedure, patient might have numbness in this area. Okay, so that is the important point I wanted to mention here. And the great saphenous vein can be cut at the ankle, or it can be cut at the saphenofemoral junction, close to the saphenofemoral junction. Okay, so when you do saphenous vein cut down close to the saphenofemoral junction, the measurement you take is 2 fingerbreadths below and lateral to the pubic tubercle. Okay, 2 fingerbreadths below and lateral to the pubic tubercle. So that is another point, and you are basically blocking the cutaneous branches of the ilioinguinal nerve when you block this. That information is not necessary. You just give local anesthesia and block it. Okay. Uh, Fascia lata. Few things about the deep fascia of the thigh, because it's a special fascia. It's a very thick fascia, and it's arranged like a stocking. That's the usual description of the fascia lata. Now we will before we talk about the attachment of fascia lata, one important thing, the abdominal fascia. Now in the abdomen you have two types of fascia. The fatty layer of superficial fascia and the membranous layer of superficial fascia. Fatty layer is called Camper's fascia, and the membranous layer is called Scarpa's fascia. Now here, at the transition from the anterior abdominal wall to the anterior aspect of the thigh, what happens is the fatty layer just continues without any disturbance, just like anywhere in the body. The fatty layer will just continue from the anterior abdominal wall into the lower limb, and that creates the superficial fascia of the thigh and the rest of it. But the membranous layer of the anterior abdominal wall, the Scarpa's fascia, it does not directly enter the thigh. It enters the thigh because it passes beyond or distal to the inguinal ligament, but immediately below the inguinal ligament, about 1 fingerbreadth or 1 centimeter below the inguinal ligament, it it fuses with the fascia lata. Okay, and that is the end of the Scarpa's fascia. That's why if you get some fluid uh, getting collected under the Scarpa's fascia in the anterior abdominal wall, like in the case of rupture of, say, bulbar urethra, you get extravasation of urine into the superficial perineal pouch, which can ascend into the anterior abdominal wall under the Scarpa's fascia. That fluid or urine or whatever will not enter the thigh, because that will stop here where the membranous layer is attached. Okay, so that is the point I wanted to raise here. Okay. Then the actual attachment of fascia lata, it's easy to start its attachment from one end and continue rather than taking here and there. So it starts the attachment. We will start from the anterior superior. We will start from the pubic tubercle here. Okay. So this is the pubic tubercle. Then it is attached along the inguinal ligament. Okay. Pubic tubercle, inguinal ligament, anterior superior iliac spine, outer lip of the iliac crest. So if you look from the posterior aspect, the rest of the attachment, okay, outer lip of the iliac crest, posterior superior iliac spine area, then the sacrum here, then from that to the ischial tuberosity and the ischiopubic ramus, and goes to the anterior side. Now there's another important point. This fascia lata splits to enclose two muscles. One muscle here in front, the tensor fasciae latae muscle, which is an important abductor of the hip joint. Then the other one is the gluteus maximus muscle here at the back. Now because of this splitting, it now the one layer, or at least both layers, they are attached to the sacrotuberous ligament also. Okay, so other than the bones, it is attached to the ligament as well. Then on the anterior aspect, if you look at the previous, the first diagram again, you see it, I said it's attached to the ischiopubic ramus. Then beyond that, it is attached to the body of the pubis. Then from that to the pectineal line. Okay, to the pectineal line. So you can see we started from the anterior superior iliac spine and went along the inguinal ligament. Now the initial part and the final part of the fascia lata, they overlap, creates an overlap, and this overlap uh, gives rise to an opening here, which is the saphenous opening through which the great saphenous vein passes and enters the saphenofemoral junction. So I'll show that here. Okay, so this is that overlap here and the opening, the saphenous opening through which the great saphenous vein goes deep. Then there's another point. On the lateral aspect of the fascia lata, there is a thickening. Okay, there is a thickening on the lateral aspect like a band, few centimeters wide, and this band extends from the iliac tubercle here to the lateral condyle of tibia. Okay, so it actually crosses two joints, hip joint and the knee joint, and this iliotibial tract is important for the action of the two muscles enclosed by the fascia lata, the tensor fasciae latae muscle and the gluteus maximus muscle. So we'll talk about the iliotibial tract later. Now, few additional things about the attachment of the two, the layers of, fascia lata. Two layers are only there where it overlaps. Otherwise, there's one layer. Okay. Now, if you take the hip bone or the pelvis here, this black dotted line is the pectineal line. If you remember the pectineus muscle, which is on the anterior aspect of the thigh, pectineus muscle is attached to the pectineal line here. Okay. Now, this is the deep or inner layer of fascia lata. Okay, this is the inner layer of fascia lata attached superficial to the pectineus muscle. So, the pectineus muscle is partially covered by this layer of fascia lata, inner layer of fascia lata here. Then, if you add the femoral sheath containing the femoral artery, femoral vein, and femoral canal, this is how you add it. So, that is further superficial to the two structures. So, the pectineus muscle is the deepest, then you have the inner layer of fascia lata, then the femoral sheath. Okay. Then the outer layer of fascia lata, now you can see the overlap here. Outer layer of fascia lata is over the femoral sheath. That's why, when you dissect the femoral triangle to see the femoral sheath and the deep structures, you have to remove this outer layer of fascia lata to enter the femoral triangle. Okay. Then you see the femoral sheath, and if you actually raise the femoral sheath and go under, what you first see is the deeper layer of fascia lata. Then actually you can access the pectineus muscle, which actually contributes to form the flow of the femoral triangle. Okay, then at the distal end, now this is the proximal attachment of fascia lata that we were discussing so far. At the distal end, around the knee, fascia lata is attached to all the exposed bony points at that point. So it's femoral condyles, tibial condyles, head of the fibula, patella, all these bony points, the fascia lata is attached to. So that's why it's a real stocking, okay, except for the opening here, saphenous opening. Then a few things about the iliotibial tract. Iliotibial tract. I already said that it splits to enclose the two muscles, tensor fasciae latae and gluteus maximus muscles. It not only encloses the two muscles are attached or are inserted into the tensor fasciae latae, the thickening of the fascia lata. Now iliotibial tract, okay, sorry, iliotibial tract. So the two muscles, they are inserted into the iliotibial tract. Now the tensor fasciae latae is fully inserted into the iliotibial tract. Gluteus maximus, most of it is inserted into the iliotibial tract, and the gluteus maximus acts on the the hip joint mainly, and indirectly through to at the knee joint. So its main action at the hip joint also mainly through the tensor fasciae, iliotibial tract. So about 2/3 of the fibers are attached to the iliotibial tract. About 1/3 of the fibers, they are attached directly to the femur. Okay, femur at the gluteal tuberosity. Okay. So remember this point. And when it comes to, and the other important point is the last point that I have mentioned here. The lateral intermuscular septum, when the thigh is divided into compartments, there are intermuscular septa dividing the thigh into compartment. The lateral intermuscular septum is actually attached to the iliotibial tract here. Okay, iliotibial tract, because that is the deep fascia of the thigh. Okay. Then iliotibial tract, through the gluteus maximus and the tensor fasciae latae muscles through the iliotibial tract can extend, abduct, and laterally rotate the hip joint. Okay, so it's the action of the muscle rather than the iliotibial tract. Okay, and iliotibial tract here at the knee, it it helps to stabilize the knee joint laterally. Okay, laterally stabilize the knee joint. And the other important thing is, which we will again talk about during locking of the knee joint. This plays an important role because when you slightly hyperextend the knee joint during locking, the relative position of the iliotibial tract and the knee joint, center of the knee joint changes. This iliotibial tract passes in front of the knee joint, and therefore, so then the force that is applied through this by the contraction of these two muscles passes in front of the knee joint after locking. So the two muscles then will contract and increase the tension in the iliotibial tract, and the knee joint will be kept like a stick. Okay, the lower limb will be kept like a stick because of the locked joint, and the quadriceps can relax. Okay, these two muscles will take the weight or whatever the force. Okay. Uh, so what happens in locking and unlocking of the knee joint is, in short, uh, okay, locking is a way of relaxing the muscles of the knee joint, like the quadriceps muscle. Um, so towards the end of extension, you can call it a slight hyperextension if you want. Towards the end of extension, uh, the lateral condyle of femur. Now you have two condyles. You have, this is the lateral condyle and this is the medial condyle. Now the lateral condyle of femur during extension, when it is extended like that, lateral condyle of femur is stopped by the tension in the anterior cruciate ligament. Okay, because the anterior cruciate ligament is attached between the anterior end of the tibial plateau and the lateral condyle of tibia. So when you extend, uh, the first thing that happens is the lateral condyle stops. I'm referring to the lateral condyle of femur. Lateral condyle of femur stops because of the tension in the anterior cruciate ligament. But the medial condyle can move further backwards. Okay. One other reason is that there's not enough space in the area of the lateral condyle, but there's enough space on the articular surface on the medial condyle of femur, because that is larger. So that allows this movement also. So then this moves back. Now lateral condyle has stopped. Medial one moves backwards. So that actually medially rotates the femur on the tibia. It medially rotates the femur on the tibia. Now if you take a look at all the ligaments, including cruciate ligaments of the knee joint, all ligaments, the directions are such that when you medially rotate femur on tibia, or laterally rotate tibia on femur, either way, because of this relative, rotation, all the ligaments, including cruciate ligaments, they get tensed. They are taut. Okay, they get tensed. They are taut, and that actually, and then the articular surface of the condyles will get tightly fitted into the cavities created by the menisci, two menisci, and the knee joint is locked. Okay, knee joint is locked. Ligaments are tensed, taut. And from that position, and as I said before, in that position, iliotibial tract now lies in front, direction lies in front of the knee joint. Okay. So the tension in the iliotibial tract created by the two muscles, gluteus maximus and tensor fasciae latae, that keeps the knee joint in that position and the muscles can relax. Okay, hope you understand this. And you cannot flex the knee joint from that point unless you uh, reverse the rotation. So the femur has to laterally rotate and relax or loosen the ligaments before it can be flexed again. So that is done by the lateral rotation of the femur on tibia can be done by the popliteus muscle, which is a muscle in the posterior compartment of the leg, which is attached to the lateral condyle of femur. So when the muscle contracts, the femur will get laterally rotated on the tibia. Then once that is done, then you can flex it again. Okay, so this is locking and unlocking of the knee joint. If someone asks you, you should be able to describe it in that order. Okay. Then few things about the compartments of the thigh. I'm not going into all the small details here, which you can easily recollect. Few things. Okay, thigh has got three compartments. Okay, and it is separated into compartments using only two intermuscular septa. So there's a lateral intermuscular septum which is attached between the periosteum of the femur and the iliotibial tract, which is the lateral part of the fascia lata there. Then you have the medial intermuscular septum. So that will separate the anterior compartment or extensor compartment of the thigh from the adductor compartment or the medial compartment and the posterior compartment. Then there's no identified named intermuscular septum between the adductor compartment and the posterior compartment. One good reason is that if you take the adductor magnus muscle, which is a large muscle, it has two components, adductor component and the hamstring component. So the hamstring part actually belongs to the posterior compartment in a way. Okay. And therefore you can't have an intermuscular septum because it's one muscle. Okay. Anyway, you have three compartments, two intermuscular septa. Then if you name the muscles, the anterior compartment is largely occupied by the quadriceps muscles. You have rectus femoris, vastus medialis, lateralis, and intermedius muscles. Okay. Then other than that, you have the sartorius muscle in the anterior compartment. Now, we will list all the muscles. Even pectineus can be included in the anterior compartment. We'll talk about it later. Then you have the medial compartment largely containing the adductor muscles, adductor longus, brevis, adductor magnus, and gracilis. Okay. Then the posterior compartment. Okay, you have the posterior half of adductor magnus. Then you have the three main hamstring muscles from lateral to medial. You have the biceps femoris, long head actually here, biceps femoris, semi tendinosus and semi membranosus. Okay. Okay, so these are the muscles. I have named the muscles for you. So you can go through this. I have already mentioned the muscles here. So the whole list of muscles is here. Now, if you go through this list, here you can see I have mentioned sartorius and the quadriceps muscles here. Then within brackets, I have put pectineus and iliopsoas because pectineus, if you look at the medial compartment also, you can see pectineus appears in the anterior compartment as well as in the medial or adductor compartment. Actually, when it comes to its nerve supply also, sometimes it gets nerve supply from the femoral artery. Sometimes in some people it gets nerve supply from the obturator, femoral nerve here, femoral nerve. Sometimes it gets nerve supply from the femoral nerve in some people, and in some people it gets nerve supply from the obturator nerve. So it is included in both compartments here and there. Then similarly, when it comes to the anterior compartment, iliopsoas, take okay. So iliopsoas, this is a muscle that contributes to form the flow of the femoral triangle. That muscle is attached to the lesser trochanter and it's a flexor of the hip joint. All that is true, but the two muscles that contribute to form it, both iliacus muscle and the psoas muscle, they belong to the posterior compartment of the uh, posterior abdominal wall. Okay, they both belong to the posterior abdominal wall, iliacus and psoas. So originally, its place is in the posterior abdominal wall rather than in the thigh. Okay, but since its the iliopsoas component, since it lies in the anterior compartment of the thigh and acts on the hip joint, some people include it as a component of the anterior compartment. It's not wrong. Okay. Coming back to the adductor compartment or the medial compartment, all the adductor muscles are there with the gracilis muscle. Again, as I said before, pectineus could be involved there because it has dual supplies and dual actions also, I think. Okay. Then the other point is some people include obturator externus also in the adductor compartment because it can adduct the hip joint. But the main ones are the ones that I have written in large letters. Okay. Then the posterior compartment or the flexor compartment, as I mentioned before, other than the three separate muscles, hamstring muscles, you have the hamstring part of the adductor magnus as well. Okay. So if you try to identify the muscles in an actual anterior thigh, you have the sartorius here. Okay. Of course, this is tensor fasciae latae. Okay. It is not taken as an anterior compartment muscle. It goes with the gluteal region actually. Laterally placed muscles, no way actually. Then you have the iliacus here. Okay. So your psoas is under the femoral artery. Okay. So psoas is covered by the femoral artery here. And then you have the pectineus muscle here. Okay. And this is adductor longus. Okay. So that's the adductor compartment. Okay. So some of these are anterior compartment muscles. So this one is obviously anterior compartment. Some people include this, even this one. And you have all, this rectus muscles which belong to the quadriceps group. Okay. Then posterior compartment, the hamstring muscles, their common origin is the ischial tuberosity here. So you have biceps femoris long head, semimembranosus, semitendinosus, and also the hamstring part of the adductor magnus. They all take origin from the ischial tuberosity here, and all these muscles are supplied by the tibial component of the sciatic nerve. I don't know whether it's okay. Motor nerve territories are there. I'll come back to it. Okay. So when it comes to the nerve supply, uh, adductor compartment is supplied by the obturator nerve. It has two divisions, anterior division and posterior division. These two divisions will supply the adductor muscles. Um, then now the anterior half of the adductor magnus, which is an adductor, it's the adductor part of the adductor magnus that is supplied therefore by the obturator nerve, that is the nerve of the adductor muscles. Then the posterior half or the hamstring half of the adductor magnus is supplied by the tibial component of the sciatic nerve. Okay, that is the common nerve for the posterior compartment muscles. Then the anterior compartment muscles are supplied by the femoral nerve. Okay, femoral nerve. Uh, it's not mentioned here. Okay, it's mentioned here. Femoral nerve. Okay. Okay, few more things about the obturator nerve. Now, there's one thing in common about the obturator nerve and femoral nerve. They actually start from the lumbar plexus, and the segments they carry, they both femoral nerve and obturator nerve, they carry the same segments, L2, 3, 4. Okay. L2, 3, 4 segments in both nerves. Only difference is that uh, from the from the anterior primary rami of L2, 3, 4, the anterior primary rami will divide into anterior and posterior divisions. From the anterior divisions, you get the obturator nerve. From the posterior divisions, you get the femoral nerve. Okay. So this is femoral nerve coming from the posterior divisions, and this is the obturator nerve coming from the anterior divisions. Of course, the femoral nerve is much larger than the obturator nerve. Okay. Uh, Then few more things about the obturator nerve. It divides into these anterior and posterior divisions while in the obturator canal. Okay. So recall where the obturator canal is. Okay. So it divides into anterior and posterior divisions while inside the obturator canal. So you can see here the obturator membrane uh, covering the obturator foramen but leaving a small space here, which is called obturator canal, if you don't remember it. Okay. So on the membrane, inside you get the obturator internus muscle attached, and outside you get the obturator externus muscle attached. Now, obturator internus has got its own nerve supply, nerve to obturator internus. Obturator externus here, it is supplied by the posterior division. Okay, it is supplied by the posterior division of the obturator nerve. Okay, so the posterior division, after supplying the obturator externus, enters the adductor compartment, passes deep to the adductor brevis muscle here, and it supplies the adductor magnus, the adductor component of the adductor magnus muscle here. Okay. And the anterior division on the other hand, okay, there's another point. This posterior division, it gives a sensory supply to the knee joint also. So if someone says knee joint is supplied by the obturator nerve, yes. Okay. Posterior division supplies it. Then the anterior division of the obturator nerve, it may or may not supply the pectineus muscle. Okay. It will supply the adductor longus and adductor brevis muscles. Adductor longus and adductor brevis muscles. Okay. And there's another cutaneous branch supplying the skin. Okay. Okay. So anterior division, it supplies the hip joint. Okay. Other than the other muscles and skin on the medial aspect of the thigh. Okay. So the posterior division supplied the knee joint, and anterior division supplies the hip joint. Okay. So in other words, obturator nerve supplies both hip joint and knee joint. You know the rule, Hilton's law. Okay. If uh, if if there is a muscle moving a joint, the nerve that supplies that muscle supplies the joint as well. Okay. There's another way of expressing it, but this is the way I use it. Okay. So this is about the anterior and posterior divisions. Okay. So I mentioned this posterior division supplies the knee joint. Okay. Then the femoral nerve, as I mentioned before, it's a large nerve coming from the posterior divisions of the anterior rami of L2, 3, 4. Okay. And it is the nerve of the anterior compartment, and it supplies all the anterior compartment muscles, and one of its cutaneous branches, it gives many cutaneous branches. One of its cutaneous branches uh, enters the leg. It passes through the adductor canal and enters the leg and supplies the medial aspect of the leg and the ankle and little bit of foot on the medial aspect. Okay, I mentioned this, it's a large nerve, but all the branches are for the thigh. Okay, all the branches are for the thigh except for the saphenous nerve. Okay, except for the saphenous nerve here. Okay. Okay. Okay, few things about the femoral sheath. Uh, Femoral sheath. Now, you have the inguinal ligament here attached between the anterior superior iliac spine and the pubic tubercle on either side. Uh, so the femoral sheath passes deep to the inguinal ligament. Okay, and the femoral sheath is formed by, as you can see here, transversalis fascia of the anterior abdominal wall here, and the iliacus fascia. Okay, so this is iliacus fascia over the iliac, uh, in the iliac fossa over the iliacus muscle. So these two fascial layers uh, extend into the thigh under the inguinal ligament. You can see the inguinal ligament here, under the inguinal ligament as the femoral sheath. Okay, uh, in it containing, or carrying femoral artery, femoral vein, and some lymph nodes and lymphatics. okay, medial to the femoral vein. The femoral nerve, it's not a content of the femoral sheath. Femoral nerve lies outside the femoral sheath, lateral to the femoral sheath here. Okay, it's not the content of the femoral sheath. So that's an important point. So this femoral sheath extends about 1 inch below the inguinal ligament into the thigh. Okay. Um, Now another important point here, anyway, we'll discuss this. Now the main branch of the femoral artery, the deep artery of the thigh, is given distal to the femoral sheath. It's not given inside the femoral sheath, it's given distal, immediately distal to the femoral sheath. Okay. Um, so if there's a block in the femoral artery inside the femoral sheath, that is actually proximal to the point at which the branch is given. That's an important, point. Okay. Okay. Now this is an actual specimen where you can see the structures here. Now this is the femoral sheath here. You can see the femoral sheath. Lateral to that, you have the femoral nerve outside the sheath. Then you have the femoral artery here, and this is the profunda femoris artery given just distal to the femoral sheath. Okay, and this is femoral vein here. It's broken actually in this specimen. This is the femoral vein. So further medial to the femoral vein, the opening is called femoral canal here. Okay, femoral canal. Now, a few things about the femoral canal. Now, the femoral canal, upper end of the femoral canal is called the femoral ring. Okay, femoral ring. This one, femoral ring. And the femoral ring is actually closed by femoral septum. Femoral septum, which is condensation of extraperitoneal tissues. Now you have the peritoneum here. This is the peritoneum. Okay. So these are extraperitoneal tissues. Okay. These are extraperitoneal tissues, fat and other connectivity. They thicken and form the femoral septum. So when you develop femoral hernia, which enters the thigh through the femoral canal here, actually the femoral hernia will push the femoral septum and passes through the femoral ring. It enters the femoral canal through the femoral ring, and then through the canal it enters the thigh and appear in the thigh, and it can get stuck at the femoral ring because that's not a very comfortable area to pass through. There are sharp edges at the femoral ring. Um, as you can see here, this is how the femoral ring is formed. The femoral ring is formed. Now, anteriorly, you have the inguinal ligament in pink color. Okay, this is inguinal ligament anteriorly. Okay, so okay, you can see the femoral ring once I do this. So then, posteriorly, you have the pectineal ligament. Okay, again in pink. Then, laterally, you have the septum separating the femoral canal from the femoral vein. Okay. Now, in the femoral sheath, there are two septa. One septum here between the femoral artery and the vein. Then there's another septum here, which is between the femoral vein and the femoral canal. So the lateral boundary of the femoral ring, therefore, is this septum. Some people, put it as the femoral vein. It's not wrong. Okay, it's femoral vein and the septum. Then the medial boundary is this sharp edge. You can see this sharp edge of the lacunar ligament. Sharp edge of the lacunar ligament. So because of this, femoral hernias can get stuck here. Okay. So that's why the femoral hernias are more dangerous than inguinal hernias, because the possibility of obstruction of femoral hernias is much more than the risk of obstruction of inguinal hernias. Okay, femoral hernias, they are differentiated from the inguinal hernias by going through the pubic tubercle. Femoral hernias are below and lateral to the pubic tubercle. Inguinal hernias are above and medial to the pubic tubercle. Okay, first thing is the inguinal lymph nodes. They are divided into two groups, superficial group and the deep group. And the superficial group lies in the superficial fascia, and the deep group lies in the deep fascia. under the deep fascia. Now, the superficial group is divided into two further groups: the vertical group, and the horizontal group. Vertical group and the horizontal group. Now, the vertical group lies along the great saphenous vein in the thigh, and the horizontal group lies below the inguinal ligament. Below the inguinal ligament, and the horizontal group can be further divided into a lateral group and a medial group. Lateral group and medial group. Medial group is more important than the lateral group. Okay, so many important structures uh, drain into the medial group, especially superficial limb, because it's superficial group of inguinal nodes. And among those structures, the conum of the uterus is also there because it drains into the medial group through the round ligament, because in females, round ligament passes through the inguinal uh, canal, and it ends at the labium majus. Okay, so through that lymph can come and enter the medial group of superficial inguinal nodes. Then uh, superficial lymph, most of the superficial lymph from the superficial nodes enter the deep inguinal nodes. Okay. Now the deep inguinal nodes, they lie medial to the femoral vein. If your femoral vein is here, they lie medial to the femoral vein. So some of them lie in the femoral triangle, and some of them they lie inside the femoral canal, inside the femoral sheath in the femoral canal. And the nodes, uh, sorry, this is external iliac nodes. Okay, so the femoral canal is somewhere here, femoral canal. Okay, and the deep inguinal nodes, they will drain into the external iliac nodes. Okay, external iliac nodes. Uh, Now the nodes inside the deep inguinal nodes inside the femoral canal, they are called nodes of Cloquet. Nodes of Cloquet, separate name is given. The areas of drainage, you can go through this quietly. You can understand what is written here. So nodes of Cloquet, I have mentioned it here. Mm, the name I have not mentioned is nodes of Cloquet, starting with C. Okay. So deep nodes, the nodes of Cloquet, they drain the glands penis in males and clitoris in females. That's why those nodes are important. The nodes inside the femoral canal. Okay. So other deep inguinal node, they drain all deep lymph and the popliteal lymph from the popliteal nodes. Superficial lymph, the vertical group drains all superficial lymph from the lower limb except for the posterolateral aspect of the leg, posterolateral aspect of the leg. All other superficial lymph goes into the vertical group. From this area, posterolateral aspect of the leg and the calf, it goes into the popliteal nodes. It goes into the popliteal nodes. Okay. So horizontal group, superficial group I'm referring to. I said the lateral one is not very important. It drains the buttock and the flank waist lateral side. Medial group is more important. I told you it drains the uterus, conum of the uterus. Other than that, it drains the superficial lymph from the anterior abdominal wall below the umbilicus. Also, it drains the perineum and external genitalia, superficial lymph from that, from males and females, and more importantly, the lower part of the vagina in females and the lower part of the anal canal in both sexes. Okay, so from the labium majus, labium minor, scrotum in males, superficial lymph will go into the medial group of superficial inguinal nodes. So we said they drain inguinal nodes, ultimately drain to the external iliac nodes, then from there into the common iliac, then the para-aortic nodes and to the cisterna chyli, and from there into the thoracic duct. Okay, few things about the femoral triangle. Now, its base is the inguinal ligament. Base is the inguinal ligament. Then the medial boundary is the medial border of the adductor longus, and the lateral boundary is the medial border of the sartorius. Therefore, adductor longus contributes to form the flow actually, but the sartorius is not. Okay, sartorius is not forming the flow, it's outside the femoral triangle. And you already know the structures in the femoral triangle: nerve, artery, vein, and lymphatics, in that order from lateral to medial. Then if you look at the structures contributing to form the flow, most laterally, you have the iliacus muscle. Then medial to that, you have the here under the femoral artery, you have the psoas muscle. Then you have pectineus here. Then adductor longus. Now to see the adductor brevis, you have to reflect the adductor longus muscle to see the adductor brevis. Therefore, adductor brevis does not contribute to form the flow because it is covered by the pectineus and mainly the adductor longus muscles. So remember that point as well. So the other important thing, it's there, somewhere in one slide somewhere, you can see another important relationship here. Now, the femoral nerve, this is the nerve, femoral nerve, it lies over the uh, iliacus muscle. Okay. Uh, Femoral artery lies over the psoas tendon. Okay. Femoral vein lies over the pectineus muscle. This is pectineus muscle. Okay. So nerve over the iliacus, artery over the psoas tendon, vein over the pectineus. Now the thing is, if you take iliacus and psoas and iliopsoas, then nerve and artery lies on the iliopsoas. Okay. And vein lies on the pectineus. Adductor canal, it is also called Hunter's canal or subsartorial canal. It is a groove. It's a canal, basically, lying in the groove formed by the vastus medialis and adductor magnus muscles. It is roofed by the sartorius and the fascia under the sartorius muscle. Okay. So this is the adductor canal. So you have vastus medialis here, and these are adductor muscles. Okay, so this is the groove formed by the two groups of muscles, and the roof is formed by fascia under the sartorius and the sartorius itself. Then inside the canal here, you get the femoral artery, then femoral vein, okay, femoral vein, and you have the femoral, but you have femoral artery, femoral vein, and the saphenous nerve. Okay, saphenous nerve, before it enters the leg, saphenous nerve passes through the adductor canal, and in the upper part of the adductor canal, you have the nerve to vastus medialis. Okay, not only in the upper part, not in the half lower part. Okay. Few things about femoral artery already I have mentioned. Femoral pulse, if you feel femoral pulse, usually you feel at the mid-inguinal point. Okay, mid-inguinal point. And when you press the artery to feel pulse, actually you are pressing the artery against the psoas tendon. Okay, against the psoas tendon, it separates the artery from the joint capsule, because deep to the psoas tendon lies the joint capsule. So you have the joint capsule, hip joint capsule like this. You have the psoas tendon, and on that you have the femoral artery like this. So we press from here and look for pulse. Okay, so this is the hip joint here. Okay, this is psoas tendon, this is femoral artery, and this is the capsule of the hip joint. Now the main branch of the femoral artery is the profunda femoris artery. Profunda femoris artery. Now take one thing clearly into your mind. So you have the femoral artery here and the profunda femoris artery here, or the deep artery of the thigh. Now radiologists, especially radiologists use two different terms for these. Now up to here it's femoral artery. Okay. Once it gives this profunda femoris artery, they name the continuation of the femoral artery. They call it superficial femoral artery. Okay. They call it superficial femoral artery. Then this deep artery of the thigh or profunda femoris, Now they call it deep femoral artery. Deep femoral artery. Deep femoral artery. Okay, so remember this nomenclature, otherwise you will get confused. Okay, so as anatomists, we usually use femoral artery and deep artery of the thigh. They use, once it is divided, they use superficial femoral and deep femoral. So superficial femoral actually passes through the adductor canal and enters the uh, popliteal fossa. Deep femoral artery, it passes behind the adductor canal actually, not inside the adductor canal. Okay, this is why it passes behind. So this is your deep femoral artery or deep artery of the thigh. Now this is the adductor longus muscle, which forms the floor of the femoral, partly, forms the floor of the femoral triangle. So your adductor canal is in front of this here. Adductor canal passes in front of this femoral artery, superficial femoral artery here, passes through the adductor canal in front of this. Now, deep artery of the thigh passes behind the adductor canal. You can see it passing behind the adductor canal here. So, in other words, the adductor longus is sandwiched between the superficial femoral artery and deep femoral artery. And the deep femoral artery, it has three types of branches, not three branches. So one is the medial circumflex femoral artery, this one, and the other one is the lateral circumflex femoral artery. Okay, this may be the one, lateral circumflex femoral artery, and then the other ones are perforating arteries. Okay, so there's a series of perforating arteries. First perforating, second perforating, like that. So it's more than three branches, but if you categorize them into group, it's medial circumflex, lateral circumflex, and perforating branches. Okay, so this is more than one. There are several perforating branches. Okay, so this is the one I was mentioning there, lateral circumflex femoral, medial circumflex femoral, and perforating arteries. Now, when naming these arteries, the the origin of the name, the lateral circumflex femoral and medial circumflex femoral, the reason for origin is because of their origin from the femoral artery. One that takes origin from the lateral surface of the artery is called lateral circumflex femoral. One that takes origin from the medial side of the artery is called medial circumflex femoral artery. Mm. And these arteries, especially the medial circumflex femoral one, is important for the blood supply of the head of the femur here. Okay, we'll talk about it later. Okay, so there's another point here. Now your femur is somewhere here. Okay, so this is the lateral side. So this is your medial side. This is your lateral side. So this is the superficial femoral artery, therefore, and this is the deep femoral artery. Now their relationship is this. So the superficial femoral artery is medial to the deep femoral artery. Deep femoral artery is lateral to the superficial femoral artery, and it is more closer to the femur. Here, if the femur is here, deep femoral artery is more closer to the femur than the superficial femoral artery. You can appreciate that in the arteriogram also here. Now, this is the femur, this is your superficial femoral artery, and this is your deep femoral artery. Okay. Now, deep femoral artery is more lateral and more closer to the femur. Okay, more lateral as well as more closer to the femur. Then ligaments of the hip joint, there are several ligaments for the stability. Three important ligaments are there. There are additional ligaments also. The most important ligament out of all the ligaments of the hip joint is the iliofemoral ligament. Iliofemoral ligament, which is a Y-shaped ligament. Okay, it's an inverted Y. It's a Y-shaped ligament. This is how it is placed, Y-shaped ligament. Now the base of the Y, this end, okay, is here. Okay, base of the Y is attached to the anterior inferior iliac spine. Okay, this is anterior inferior iliac spine. Your anterior superior iliac spine is somewhere here. Okay, so then the two limbs of the iliofemoral ligament, the Y, is attached to the intertrochanteric line here. This is the intertrochanteric line on the anterior side. and it prevents overextension of the hip joint. Not only this one, the other two ligaments also, they prevent overextension of the hip joint. Okay. Then the second one, pubofemoral ligament, which is a triangular shaped ligament. This is pubofemoral ligament. So the base of the triangle is at the ramus of the pubis. Okay, base of the triangle is here at the ramus of the pubis. The apex of the triangle again on the intertrochanteric line. Intertrochanteric line. So it does two things because of its position. It prevents not only overextension, it prevents over abduction also. Okay, it limits abduction as well as overextension. Then the third ligament, ischiofemoral one, that lies on the posterior side, unlike the other two ligaments, and it is an oblique ligament. It starts from the body of the ischium, okay, body of the ischium here, and it is attached to the greater trochanter. Okay, attached to the greater trochanter. Again, it prevents overextension. That's why I said all three ligaments, they prevent overextension. Then you have other ligaments. You have the transverse acetabular ligament here, okay, which bridges the notch in the acetabulum here. And then you have the ligamentum teres, or the ligament of the head of the, this one, ligamentum teres, or ligament of the head of the femur, this one, okay, which attaches the head to the acetabulum. Now, relations of the hip joint, uh, I will not talk about the relations of the hip joint here, which will take time. Now I have nicely, written it here. You carefully go through it and study it. Okay. So, and I said before also how the vein, the nerve, artery, and vein are related to the muscles underneath. And I said the hip joint is deeper to the muscles. Okay. So go through this and go through this slide also, which I'm not going to read, how the different structures are related to the hip joint superiorly, inferiorly, and posteriorly, which I have mentioned here, superiorly, inferiorly, and posteriorly. Okay, just go through it for the completeness. Okay. So then laterally and medially also. Okay. So medially, one important thing when it comes to the medial relations of the hip joint, uh, not to forget that you have the pelvic cavity here on the medial side. Uh, so ovary, your ovary lies somewhere here in this red circle, which I'm showing here, red circle, and therefore obturator vessels and nerves, they are sandwiched between um, the ovary in a female here, and outside you have the acetabulum, okay, hip joint. So say if you have a fracture of the acetabulum, where the head of the femur is driven into the pelvic cavity. So in a female, ovary is at risk, and in both sexes, these obturator vessels and nerves are at risk of damage. If the head of the femur goes into the pelvic cavity, fracturing the acetabulum. Then a few things about the collateral circulation of the femoral artery. Uh, Now, actually, I didn't talk about the cruciate and trochanteric anastomosis. Okay, I'll talk about it first and come back to this. Now, there are two types of anastomosis, trochanteric and cruciate anastomosis in relation to the hip joint. Now, the trochanteric one is more important than the cruciate, I think. So, trochanteric one is around the trochanteric fossa, and the cruciate one is at the lesser trochanter level. Now, the trochanteric anastomosis is formed between the descending branches of the superior gluteal artery and the ascending branches of the inferior gluteal, medial femoral circumflex, and lateral femoral circumflex. So that is trochanteric anastomosis. Okay. Then the cruciate anastomosis, the superior gluteal is not involved in the cruciate anastomosis. It is between the inferior gluteal, this one, okay, then medial circumflex femoral and lateral circumflex femoral again, and the first perforating artery. Okay, so this is the first perforating artery. Okay, so ascending branches of the first perforating artery anastomosed with the descending branches of the inferior gluteal artery and the transverse branches of the circumflex femoral arteries. That is the lesser, the cruciate anastomosis. So now what are the two arteries? What are the two systems that are anastomosed here? Now superior gluteal, this one, superior gluteal artery and inferior gluteal artery, they are branches of the internal iliac artery. Okay, internal iliac artery. They are branches of the internal iliac artery. Now the femoral artery is a continuation of the external iliac artery. Now this deep artery of the thigh is a branch of the femoral artery. Now if the femoral artery is obstructed, okay, if the femoral artery is obstructed at a proximal place, somewhere proximally here, blood can deviate from the internal iliac artery, goes through trochanteric and cruciate anastomosis and enter the profunda femoris artery or the deep artery of the thigh through these anastomosis through the lateral and medial circumflex femoral and the perforating arteries, first perforating artery. And blood can retrogradely pass along the deep artery and enter the superficial femoral artery if the block is very proximal, like in the femoral sheath area. Okay. So that's what I mentioned here in the previous slide. So a proximal femoral artery occlusion, okay, proximal femoral artery occlusion through cruciate and trochanteric anastomosis, blood can enter the femoral, superficial femoral artery through circumflex femoral arteries and first perforating artery along the profunda femoris artery. Okay. So on the other hand, if the obstruction is distal, if the obstruction is say somewhere here, after the deep artery of the thigh is given, okay, deep artery of the thigh is given, then you don't need cruciate and trochanteric anastomosis anymore because blood can now directly enter into the deep artery of the thigh from the femoral artery, and the blood can bypass the block and enter the femoral artery distally here from the deep artery. Okay, so this is how they enter the deep artery through the perforating branches of the profunda femoris artery. There are muscular and articular branches of the femoral and popliteal arteries. Okay, so through them they can enter, and the arterial anastomosis around the knee joint, okay, which is called genicular anastomosis. So all through these muscular branches, articular branches, and genicular anastomosis, you can get blood passing from the deep artery of the thigh or the deep femoral artery into the distal part of the superficial femoral artery and the popliteal artery. Then the other important thing is when it comes to the blood supply of the head, the vessels that supply the head ultimately are called retinacular arteries. They pass along the neck of the femur to supply. Okay, so they pass along the neck of the femur and they are fed by the branches of the trochanteric anastomosis mainly, and out of all the branches, the most important one is the medial circumflex femoral. Rather than the lateral one, medial one is more important, and the retinacular arteries are given off from uh, the, the the trochanteric anastomosis and the medial circumflex here. And if you fracture, and these are, subcapsular, subsynovial arteries. If you fracture the neck, especially in intracapsular fractures, you can damage the retinacular vessels and head of the femur can undergo avascular necrosis because unlike in children before puberty, head is, in adults, head is largely depend on the cruciate, the trochanteric anastomosis blood supply. In children, actually, there is an alternative blood supply through the ligament of the head of the femur, through the obturator artery. Okay, through the obturator artery, they get a blood supply. But when they grow old and old, that supply becomes less and less, especially after closure of the epiphyseal plate here. After closure of the epiphyseal plate here, the role of the obturator artery becomes almost negligible. So in adults, that's supply totally dependent on these arteries. Okay, so if you fracture the neck, then it's at risk. So I have mentioned here about the retinacular fibers and their position, as you can see here, the retinacular vessels pass like this. Okay, so they are called subsynovial because your synovial membrane is reflecting here. Okay, and so the retinacular fibers of the capsule themselves stop at the hyaline cartilage here. Okay, so the vessels also stop there and they supply the head. Okay. Okay, I have mentioned whatever I described here. Okay. Then few things about the fractures themselves. Now I'm not going to talk about different types of fractures, but intracapsular fractures are the ones that are at risk of avascular necrosis. And if the fracture is more towards the head, like subcapital fractures just below the head, those are at the highest risk. Those are at the highest risk. The more you go towards the intertrochanteric line, the less risk of avascular necrosis, from what I understood. Okay, so then if the fracture is extracapsular, uh, then the risk is not there actually. Okay, and remember another point. Say if the fracture line passes along the intertrochanteric line here, remember that the capsule at the back posteriorly, the capsule falls short of the intertrochanteric crest here. Okay, it is attached to the intertrochanteric line in front, so the retinacular vessels start from here and go that way. On the posterior side, since the capsule falls short of the intertrochanteric crest, which is here, okay, on the posterior side, then the retinacular fibers pass from here to here, so it's short. So if your fracture line is here, for instance, so on the anterior side, okay, vessels will get damaged, but the posterior side, vessels are intact. So the chances of avascular necrosis would be less.